Thanks for hosting this. Look at all these attendings. It feels like a oral board simulation. So the name of my presentation is Preliminary Axillary Bypasses for Distal Aortic Perfusion during Thoracoabdominal Aortic Aneurysm Repair. No disclosures. We all know that proximal aortic clamping during open thoraco repair has a lot of ischemic consequences. Distal aortic perfusion in the most common form is left heart bypass along with CSF drainage and other adjuncts is very important for improving outcomes, notably spinal cord ischemia. Preliminary axillary bypass is an alternative form of distal aortic perfusion. So here we describe a case of a failed EVAR for aneurysmal degeneration of a chronic type B aortic dissection requiring endograft explant and open repair of an extent 3 thoraco utilizing PAB for DAP, which is preliminary axillary bypass for distal aortic perfusion, followed by a staged TVAR landing distally in the Dacron graft. And I know this theme of this conference is working together, but unfortunately we had to do this all by vascular surgeons, which is why we ended up using this strategy. We have a 59-year-old male with a chronic type B aortic dissection. He's undomiciled. He's relatively healthy, good cardiac function, no pulmonary disease, good kidney function, but he's a polysubstance abuser and has uncontrolled hypertension. He presented with persistent severe chest, abdominal, and back pain and hypertension requiring IV beta blockers, but was otherwise hemodynamically stable. 2 days prior to his presentation, he had been evaluated in an outside institution. He was found to have aneurysmal degeneration for his chronic type B aortic dissection. He underwent EVAR. Despite this repair, he had persistent symptoms, and therefore a repeat CT scan was obtained. Here, oh shit. Sorry. All right, so here's the CT scan. So some notable anatomic findings. There's going to be an EVAR main body graft with detached external iliac artery stents. There's a type B aortic dissection beginning at the level of the 7th thoracic vertebrae. It extends to external iliac arteries. There's a short thoracic aneurysm portion that's not dissected proximal to this. It's about 5 centimeters starting around T5. The entire dissected aorta was aneurysmal. The maximum diameter was 7.1 centimeters. The celiac, SMA, and renal arteries and common iliac arteries all arise off the true lumen. And the distal false lumen remained perfused despite the dissection. The infrainguinal arteries are disease-free. There's no significant variant aortic anatomy, no significant intra-aortic calcifications, thrombus, angulation, tortuosity, or aberrant aortic shape. And there's a good size diameter throughout the aorta. So what are our treatment options? We can first mainly take into 2 considerations. The patient's very young. He's 59 years old. He's got very good physiologic reserve, and he's acutely symptomatic, so that influenced our decision. We can think about a total endovascular repair. Unfortunately, we don't have a ton of experience with PMEGs, so that's out. We could do a multi-vessel chimney repair with like 4 stents, and we don't think the durability for that is good, and there's probably not a lot of good bailouts for that later down the line. And then, we wanted something more predictable and durable. So we could go with a total open aortic repair. It would be essentially an extent 2 exposure. And as you know, it's a very, very big physiologic insult. It's a very hard surgery. You got to get really, really high up on the aorta. You got to clamp very, very proximally. And the rates of type 2 thoracoabdominal aortic repair spinal cord ischemia is about 22%. So we decided to go with a hybrid repair. We're going to do a type 3 aortic abdominal aneurysm repair, and then we're going to cover the most proximal portion with the TVAR. Especially, he's got persistent symptoms and hypertension requiring IV medications, and these radiographic findings, we're concerned that we have to act urgently. So our CT surgeons are occupied. They don't want to help us with this case, so we're going to have to do this preliminary axillary bypass, which has essentially been previously described, but even when it was first described around the early 90s, it's not very popular because it takes a little bit longer. But it's essentially, you can do it only with vascular surgeons. You do an axillary bypass, you feed the distal aorta, the common iliac arteries or the femoral arteries, you get some retrograde perfusion through there to your gut. And in this case, because we have to do the graft explant, we decided to do a right-sided axillary bypass to feed the celiac and the SMA while we try to fish out this EVAR. And then also, you don't really need as much heparin as you do for left heart bypass. So here are intraoperative steps. We use a spinal drain preemptively. We normothermia. The patient's initially supine. We do our bilateral axillary cut downs. On the right side is a standard ax biofem. On the left side, we do an axillary to graft endoside anastomosis. And then we place the grafts in the pocket. We close the wounds. We reposition the patient. Next, we flip them to modify the right lateral decubus. We do an 1/8 intercostal space incision on the left side. And then we do our proximal repair up to around the level of T7. We use a superceliac clamp. We use rifampin soaked Dacron tube graft of 20 millimeters diameter as our proximal graft. We do a wedge excision of dissection flap. Our proximal anastomosis is done with pledgets. And then we sometimes will ligate the lone intercostals, but sometimes we'll save the island of intercostals. This is borrowed from Dr. Black. This is a little illustration. Next, we clamp the common iliac arteries, we open the sac. We put cold perfusion in the bilateral renal arteries, and then we feed the SMA and the celiac artery with our left axillary graft. We excise the EVAR main body. It was a Gore device. And then we anastomose the celiac, SMA, and right renal as a Correll patch, and the left renal artery as a button. And then we ligate the common iliac origin, and we leave the iliac limbs in situ. And then the distal anastomoses are to the bilateral CFAs, and then we remove the bypasses. Here is the post-operative CT scan about 2 weeks later. So the patient did well, no post-op blood transfusions. He was extubated the next morning. He was on room air by post-op day 5. He has good normal urine output throughout his post-operative course. Spinal drains out by post-op day 6. We had to keep it a little bit longer because he had some non-specific lower extremity weaknesses. But and then 2 weeks later, on post-op day 16, he returned to the OR for his thoracoabdominal aortic, his TVAR. So here you can see the aneurysm portion, and then this is post TVAR deployment. We did a single grain cut down via left femoral, and then we inserted the TVAR through the Dacron limb. We used the Gore tag, 28 by 10 and 34 by 15 distally. There were 22 French sheath. It proceeded without issue, and we landed in our Dacron tube graft for the distal part of our TVAR. So in conclusion, preliminary axillary bypasses can be used for distal aortic perfusion during thoracoabdominal aortic aneurysm repair, and a hybrid thoracoabdominal aneurysm repair can reduce the complexity of a total open thoracoabdominal aortic aneurysm repair. Thank you.